Welcome to another lesson, everyone. My today's topic is about septic arthritis in children. To start from the definition and the etiology, septic arthritis is an infection in the joint or synovial fluid and the joint tissues. And the different types of bacteria, virus, and the fungus can infect a joint. Staph aureus is the most common cause of bacterial arthritis in all age groups, starting from the neonatal period. And other common cause of septic arthritis include group A streptococcus, strep pneumonia, and Klebsiella kingiae. In sexually active adolescents, gonococcus is a common cause of septic arthritis and tenosynovitis. Neisseria meningitis can cause either septic arthritis that occur in the first few days of illness or a reactive arthritis that is typically seen several days after antibiotics have been initiated. Group B streptococcus is an important cause of septic arthritis in neonates. Fungal infections usually occur as a part of multi-system disseminated disease, and Candida arthritis can complicate systemic infection in neonates with or without indwelling vascular catheters, and primary viral infection of joints are almost rare. A microbial etiology is confirmed in approximately 65% of cases of septic arthritis, and in addition, some cases treated as bacterial arthritis are actually post-infectious reactive arthritis rather than primary infection. When we see the epidemiology of septic arthritis, this septic arthritis is more common in young children. Half of all cases occur by 2 years of age and 3/4 of all cases occur by 5 years of age. Adolescents and neonates are at risk of gonococcal septic arthritis, and most infection in otherwise healthy children arise hematogenously. Less commonly, infections of joints can follow penetrating injuries or procedures such as trauma, arthroscopy, prosthetic joint surgery, interarticular steroid injection, and orthopedic surgeries. And immunocompromised patients and those with rheumatologic joint disease are also at risk of joint infection. Regarding pathogenesis, septic arthritis primarily occurs as a result of hematogenous seedings of the synovial space, and less often, organisms enter the joint space by direct inoculation or extension from a contagious focus. The synovial membrane has a rich vascular supply and lacks a basement membrane, which provides an ideal environment for hematogenous seedings. The presence of bacterial products within the joint space stimulates cytokine production within the joint, triggering an inflammatory cascade. The cytokines stimulate chemotaxis of neutrophils into the joint space, where proteolytic enzymes and elastase released by neutrophils damage the cartilage. Proteolytic enzymes released from the synovial cells and the chondrocytes also contribute to the destruction of cartilage and the synovium. Bacterial hyaluronidase breaks down the hyaluronic acid in the synovial fluid, making the fluid less viscous and diminishing its ability to lubricate and protect the joint cartilage. Damage to the cartilage can occur through increased friction, especially for weight-bearing joints, and the increased pressure within the joint space from accumulation of purulent material can compromise the vascular supply and induce pressure necrosis of the cartilage. Synovial and the cartilage destruction results from a combination of proteolytic enzymes and mechanical factors. When we see the clinical manifestation, most septic arthritis are monoarticular. The signs and the symptoms of septic arthritis depend on the age of the patient, and early signs and symptoms might be subtle, particularly in newborns. As with osteomyelitis, neonates might exhibit pseudoparalysis or pain which limits voluntary movement of the affected extremity. Septic arthritis in neonates and the young infants is often associated with adjacent osteomyelitis caused by transphysial spread of infection, although osteomyelitis contagious with an infected joint can be seen at any age. Older infants and the children might have fever and pain with localizing signs such as swelling, erythema, and worms of the affected joint. With involvement of joints of the pelvis and the lower extremities, limp or refusal to walk often occurs. Erythema and edema of the skin and the soft tissue overlying the site of infection can be seen. And the elbow, wrist, and the shoulder joints are involved in approximately 25% of cases, and small joints are uncommonly infected except in gonococcal arthritis. Suppurative infections of the hip, shoulder, elbow, and ankle in infants and children might be associated with adjacent osteomyelitis of the proximal femur, proximal humerus, proximal radius, and the distal tibia because of the metaphyseal extends interarticularly. Concomitant osteomyelitis is less common in older children and adolescents as their anatomy and physiology become more adult-like. Septic arthritis involving the knee joint is the most common one. It is responsible for around 35%. This is followed by hip, ankle, and elbow, and upper extremity joints are less commonly affected, and the small joints are almost rare. Regarding diagnosis, elevated WBC count, CRP and ASR is there, but it's non-specific. And blood cultures are positive in 20% or fewer cases of proven or probable septic arthritis. Even though we should have to send blood culture for all children with septic arthritis. Cervical, anal, and throat culture should be obtained when gonococcus is suspected. And aspiration of joint fluid provides the optimal specimen to confirm the diagnosis. Most large joint spaces are easy to aspirate, but for hip, we need ultrasound guidance to aspirate the joint fluids. We should have to send synovial fluid culture, even though the yield is better than that of bleed culture. It is less positive. The positivity rate is around 50%. And synovial fluid analysis for cell count, differential, protein and glucose has limited utility in diagnosing infectious arthritis. And joint fluid weight blood cell count greater than 50,000 suggests bacterial infection as the most likely etiology. But this finding is neither sensitive nor specific enough to exclude or to confirm a bacterial infection in isolation. Monitoring elevated CRP might be of value in assessing response to therapy or identifying complications to diagnose septic arthritis. In addition, patients with adjacent infection complicating septic arthritis more frequently have elevated CRP more than 10 mg per deciliter compared with patients with septic arthritis alone. The other thing is about radiographic evaluation. Radiographic studies play a crucial role in evaluating septic arthritis. Conventional radiographs and ultrasonography are performed as a part of the routine workup, whereas CT and MRI and other radionuclide studies are indicated if needed. Plain radiographs can show us widening of the joint capsule, soft tissue edema, and obliteration of normal fat lines. And plain films can also help to exclude other causes of joint pain such as fractures. And plain films of the hip can show medial displacement of the obturator muscles into the pelvis, or which is called obturator sign, and also lateral displacement or obliteration of the gluteal fat line. Ultrasonography is included with plain films in routine evaluation because it is particularly helpful in detecting joint infusion and fluid collection in soft tissue and also subperiosteal region. And it is highly sensitive in detecting joint infusion, particularly for the hip joint, where plain radiographs are normal in more than 50% of cases of septic arthritis of the hip. And they can serve as an aid in performing hip aspiration also. MRI and CT can confirm the presence of joint fluid in patients with suspected osteoarthritis, but they are not routinely indicated. MRI is useful in evaluating for adjacent osteomyelitis or pyomyocytes, but it's typically reserved for cases when the index of the patient for this condition is high. When we see treatment of septic arthritis, optimal treatment of septic arthritis require cooperation of pediatricians, orthopedic surgeons, and radiologists, and appropriate antimicrobial therapies are needed. And the initial empirical antimicrobial therapy is likely based on bacterial pathogens at various ages, the result of the gram stain of the aspirator material, and additional considerations. In neonates, anti-staphylococcal penicillin such as cloxacillin and the broad-spectrum cephalosporin such as ceftriaxone or cefepime can be used. And in older infants and children with septic arthritis, empirical therapy to cover Staphylococcus, Streptococcus, and Klebsiella kingiae such as vancomycin, clindamycin can be used. Duration of antibiotic therapy is individualized depending on the organism isolated and also the clinical course. Normally for group A Streptococcus, Strep pneumonia, and Klebsiella kingiae, 10 to 14 days is adequate, whereas longer therapy might be needed for those who have extensive disease, slow response to treatment, or gram-negative infection and Staphylococcus. 3 to 4 week treatment may be needed in those cases. And if there is concomitant osteomyelitis, up to 4 week treatment is needed. Normalization of CRP in addition to normal examination supports discontinuation of therapy. Oral antibiotic can be used to complete therapy once the patient is afebrile for 48 to 72 hours and it is clearly improving. Regarding surgical therapy, infection of the hip is generally considered a surgical emergency because of the vulnerability of blood supply to the head of the femur, and for joints other than the hip, daily aspiration of synovial fluid might be required. In general, 1 to 2 subsequent aspirations suffice. If fluid continues to accumulate after 4 to 5 days, arthrotomy or video-assisted arthroscopy is needed. Regarding prognosis, improvement in signs and symptoms occur rapidly following joint drainage and antibiotic administration. Failure to improve or worsening by 48 to 72 hours require a review of the appropriateness of the antibiotic therapy, the need for surgical intervention, and also correctness of the diagnosis. And acute phase reactant must be useful as monitoring, and failure of either of this acute phase reactant to follow the usual course should raise concern about the adequacy of therapy. And recurrence of disease and the development of chronic infection after treatment occur in less than 10% of patients. And septic arthritis can lead to numerous long-term sequelae in children, including leg length discrepancy, angular deformity from growth arrest, limitation in range of motion due to chondral damage, avascular necrosis of the femoral head from septic arthritis of the hip might occur. The overall rate of the sequelae with current therapies is less than 5%, and children are in a dynamic state of growth, so these abnormalities may not become apparent for months or years. Therefore, long-term follow-up is necessary with close attention to range of motion of joint and bone length. Thank you for your attention and also for subscribing to this channel. Have a nice time.